Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
But I will do my best here. So I'm Carol Laird. I am a weapons physician at Medical Center, currently in my second year at residency. With me, I have Captain Steve Radloff, one of our attendings at Magan, and also with 2-1 is the battalion surgeon. So today we're going to talk about a case that's essentially pretty well known, of an incident that happened relatively recently. We'll go to essentially the entire medical force of what happened, basically the first 12 hours. A little peek at outcomes, and of course lessons learned from that day. So standard disclaimer, these are our views, not to be used in the Army or in DoD. We do not have any affiliations financially or commercially to disclose. So jumping right into this case, so this was a 26-year-old gentleman who was brought in by unit and vehicle to Madigan Emergency Department. We did not get a heads up that there was this patient coming. They just showed up the emergency room doors. In the field, it was stated that the patient had some shortness of breath, and so what they ended up doing was a right-sided needle decompression, which was later found to be subcutaneously placed. On arrival, the patient was brought back to the trauma bay, and a full trauma was called. So what that is at Madigan is essentially it doesn't activate only emergency medicine staff, but it also activates general surgery, anesthesia, come on down, opens up the CT scanner, gets rads in the room for x-ray, and then also gets emergency release blood in the trauma bay as well. So the story that was told to the providers who were on that night is that a flashbang went off, this patient was short of breath, and that was the suspected source of injury initially. So the patient's initial vitals included a heart rate of 132, a blood pressure of 175 over 146, respiratory rate of 32, and an SpO2 of 91% on a Romer. So he's probably placed some 5 liters nasal cannula with resolution of his relative hypoxia. His shock index at that time was 0.75. So for those of you not as familiar with shock index, essentially what it allows us to do is try and see, hey, is this person potentially in shock, even though they had a normal blood pressure or maybe are even hypertensive. So the way that is done is that you divide the heart rate over the systolic blood pressure. And so a normal shock index is usually around 0.5 to 0.7. Anybody with a shock index of 1 or greater, you should basically be pretty concerned that, hey, this person might be in shock. So initial exam for this patient, there was no obvious hemorrhage when he rolled in. He's talking to everybody, GCS 15. When they oscillated his lungs, he didn't have any adventitious sounds, so he had great bilateral breath sounds, and he didn't have that needle D on that right side. Pulse is present in all 4. The big thing from this is that the patient was not exposed entirely prior to coming into the emergency department. His shirt was cut, but nothing else. So on that secondary exam where we fully take off all their clothing and roll the patient as well, it was found that this individual had 2 small penetrating luteal injuries when they Goldten. So this is a patient's chest x-ray. Usually as part of a trauma series, we'll get a chest x-ray, pelvic x-ray, and sometimes we'll do a fast exam as well. So in this case, we don't see any pneumothorax, we don't see a chemothorax, the mediastinum is within normal limits. And then you'll see kind of around that second intercostal space on the right side where that needle D was initially placed. There is a catheter that you can kind of see now down near the diaphragm, and so that was probably just a IV attempt where the catheter is just under the patient, so ignore that. As far as the pelvic x-ray for this individual, there was found to be radiopaque fragments essentially in the pelvis and also in the right glute area. They did a fast exam at this time too. They actually did a EFAST, so there was no pneumothorax noted on the EFAST, and then no blood noted as well. So negative exam. So with all this in mind, the next steps, they did a repeat set of vitals, and at this time, the patient still had a GCS of 15, and they said, hey, I think this patient is stable enough, we'll send them to the CT scanner. And so at this time, the emergency release blood was also sent back to the blood bank. So usually what will happen is they'll run up a cooler and then they'll ask you, hey, do you need this anymore? And because this patient was perceived as stable, they ended up saying, hey, we'll just return it. And so the patient was sent to the CT scanner, and because of the perceived stability of this individual, they ended up not sending an ER provider to CT scan with this individual. They had a junior Cert 4 resident. And so normally what we'll do for any individual who has some type of abnormal vital signs is we'll send a provider. At Madigan, we have multiple providers on, so we have that resource, thankfully. And so we'll send somebody with them to CT in case any interventions sneaked or performed while they're over there, since it is still a bit of a journey back to the ER. So unfortunately, there's a saying in emergency medicine that CT is where your patients go to die. And this individual had some decreasing mental status while he was in the CT scanner. They checked his vitals, saw blood pressure that seemed kind of erroneous, but then when they repeated his blood pressure, these were his new vitals. And so his heart rate was 142, blood pressure 70/50 respiratory rate 26, still doing great on that 5 liters nasal cannula, but a shock index, that cardiac rate over systolic blood pressure, was now 2. And so this individual was absolutely in shock. So this is his CT scan. And so there were kind of multiple things that happened all at once. So essentially the patient rolled back to the trauma bay. There was a call from radiology, essentially with a wet read, saying, hey, there's a lot of blood in the pelvis, and it looks like both iliac arteries are bleeding. A FAST was repeated at that time, too. Again, this all kind of happened simultaneously. And the FAST exam was positive now on the left upper quadrant. And so here's a great image where you can see the entry route, the exit, and then also part of the round. So a lot of things happened all at once. There's multiple people in the trauma bay performing these different interventions. So the patient at this point received CXA, they got calcium, they got hospital appropriate antibiotic, this case being ANSA. And then the emergency release blood that initially was sent back to the blood bank, Winner was sent to collect it and bring it up. So this was all going in through a Belmont, that rapid infuser. And so at this time, the emergency medicine resident placed a right femoral central line. And then also the surgery resident was starting to do a cut down on the left inguinal area in order to place over BOA. And the reason why this was done was because when they called for the OR was no longer ready. And so they still had to go ahead and prep the OR before we could send the patient out there. So after you have emergency release blood, which at Madigan is 2 units of PRVCs and 2 units FFP, there is the ability to call for MTP. So this is massive transfusion protocol. And so at different hospitals, you might have full blood, but at Madigan, we still use components. And so the MTP coolers consist of 4 units of PRVC and 4 units of FFP, and then they alternate cryo and precipitate every other cooler. And the coolers come up about every 15 minutes, and they're only called out once the MTP is called out. And so while the MTP initially got to the trauma bay, and the patient received an additional 2 units of PRVC, additional 2 units of FFP, the individual, they were about to go to the OR. And so the OR was finally ready. They started rolling down. And essentially what happened is the patient had even worse than GCS. He was not maintaining his airway. And they said, hey, we can't roll this guy, down the hall, down this other hall, and then up an elevator. And so what we need to do is we need to roll him back. We need to take his airway, and then we'll send him up. So they went back to the trauma bay, and they prepared for intubation. And at this time, the MTP still went over to the OR. So this resulted in the patient essentially having a 10-minute delay of any additional blood product. So the intubation was successful, not without its own issues. This individual was given ketamine and rock in order to intubate, and then also push-dose epi was prepared. And so the push-dose epi was given in 10 to 20 microgram allotments, and then essentially it was used basically just to support and block that parasympathetic response of the laryngoscope. The patient did not tolerate the procedure very well despite all of the norepi that was given. He had at one point a blood pressure of like 50/36, but with a little additional push-dose epi, he stabilized and they transported him to the OR. So when they did an X-lab, they found that there was a sigmoid colon 2 centimeter through injury. They saw stool in the abdomen. And then they saw this massive hematoma with extension all the way from zone 3 up to zone 1. So the revolve was not completed in the ER. The revolve was actually completed up in the OR. And at that time, it kind of bought them a little bit of extra time in order for vascular surgery to show up. And so it's kind of an unknown amount of time how long the revolve was actually up for before vascular surgery came in. They likely were not in-house because this event happened later at night. But it's still on call and still to get to the hospital in a certain amount of time. So once the vascular surgeon was there, he cross-clamped the aorta. They were able to visualize that there was not a zone 1 injury. Everything was distal to the bifurcation of the aorta, and it cut down essentially the dissection down into the iliac arteries. The presumed amount of time that the aorta was cross-clamped was 30 minutes, is the documentation. Again, with unknown ROBOA time. So this was a sheer amount of product a patient just got on their first operation. So in addition to 4 and 4 in the emergency department, he got 22 units of PRBC, 18 of FFP, 4 units of platelet, and then 3 units of cryo. And essentially, the reason why we're not necessarily saying like a 1-to-1-to-1-to-1 ratio here is that they used a TEG, also known as a thromboelastogram. And so essentially what that does is it lets you see what components the patient needs in order to transfuse them and allow them to clot appropriately as well. And so that's essentially why we're seeing these abnormal numbers. So the patient was then taken back a few hours later to the OR. He had a wound vac in place. They let this abdomen open. And he had increasing output from that wound vac, as well as increasing pressure gains. And so what they found was that he had some venous injury, he had some arterial injury, hematoma around that original ROBOA site. And so they repaired these issues and gave him the below blood products that you see. So this is the amount of blood product that the patient receives at about 10 to 12 hours on initial arrival to the ER. And so as we'll see at the audible left, this is 70 units of product. This is a massive amount of product that this individual received. So ultimately what they ended up having to do is then perform the colostomy on this individual. He had multiple sacral fractures that required him to be non-wayfaring for 6 weeks. His hospital course was extremely complicated. He had an abscess formation, he had ATN, rhabdo, shock liver, neurogenic bladder, and spinal shock as well. Initially, he had a lack of sensation over the dorsum of both feet, and then weak movement of the toes on the left side and no movement on the right. They were trying to characterize it further, but of course he couldn't have an MRI because he had retained fragments. But obviously the suspicion was the ROBOA was up for 30 plus minutes, the total time that he was frostbite plus ROBOA was 30 plus minutes. And so neurosurgery suspected that, hey, this is due essentially to the ischemia from the prolonged time being cross-linked. So the investigation later found that this was indeed not a flash bang that entered this patient. It was a live round that somehow made it into a like-fire training exercise. So the patient was ultimately discharged to an inpatient rehab facility. This was 26 days after his initial presentation. I was going for his records, and honestly, like to date, he ambulates with bilateral leg braces plus a walker. He'll use a wheelchair in order to ambulate longer distances. He does have regained sensation in both of his feet, but he has a pretty profound atrophy below the right knee. And basically, the suspected outcome is he's not going to get any more recovery for that lower extremity. He does still have a colostomy present, and hopefully plans for reversal here shortly. So I'm going to hand it over to Dr. Redloff for a moment. I'm going to talk about the pre-hospital side of things.
Hey there, I'm Steve Redloff. If you were here earlier, you suffered through my talk before. I am an ER doctor now. I was a priority Delta in the NCICU SOCM for a period of time. I've definitely sat at SOMA lectures and cringed as people Monday morning quarterback, and I'm going to do that. But I do want to say that ultimately, there was an HC Delta on the ground who recognized that this patient needed to go to the hospital urgently, and he did. The ER recognized that this patient needed the immigrants needed to go to the OR urgently, and he did. The surgeons recognized that this patient needed a vascular surgeon urgently, which they call. And this patient is alive today because of the care he got. I am going to Monday morning quarterback because there's some things really at all levels we could have done better. But this is not to cast aspersions on anyone, and to recognize that this guy did live when he definitely would not have had everybody not met the minimum standard. As a prior SOCM instructor, I always taught, and I continue to teach my medics, that in teacher IC, what do I need for a needle drill, right? Like, what do I need for a needle B? And it's MOI and dyspnea. This patient was short of breath. That's reported from court of injury. He had dyspnea. He had a 91 SpO2 when he arrived at the ER. I think that's totally fair. I had a hard time figuring out what his mechanism was that caused the needle decompression. I don't think a flashbang is a great answer to that, and I don't think that, and that wasn't the case, and I don't think that the penetrating GSW, the lower torso, is a great answer for that eyewear. That said, where I struggle is, how did we figure out laterality? So at some point we decided this was a right-sided, not bilateral needle bead. And where I struggle most is that you can see this is actually the CT image of it. Best of both worlds, this is an anterior axillary second intercostal space. So this is directly through the patient's pec. And I don't know if is there a pull lesion? Nope. Oh, I found the pull lesion. Hold on. So if you look, this is where it's at, and then right here outside the photo face is where it landed, and it's going to be right there, baby fair. That hurts my feelings. And again, I'm not sure how we landed there. We did. In the SOCM course, I know that one of the things we hammer is downside checks and blood sweeps. This patient arrived to the ED still wearing his pants. And this is not a dime taped to the bottom of somebody's foot, right? Like, this is penetrating trauma that was unexposed in the lower torso and really would have chafed it. There are some complicated factors, and this is kind of still under investigation. It was a live brown that was in 249 link. And it was a real-world patient right around the time the unit had planned the training patient. So you can imagine being AT Delta if we expected there to be a fake patient right then and expected that you were doing non-live fire exercise and what it would have taken to shift mind frames. So really, there's a lot of good reasons why things could have gone wrong, and it just kind of reinforces to me that the basics we have to hit until they're straight up muscle memory. As the 10 being in the ER now, one of the things I teach all my residents is the ABCDs, which is always be considered a dispo. As soon as they realized this guy was going to the ER, somebody should have told them, whether that's a call to range control over to the hospital or on JBLI, and everybody should know, every medic should know 1390 is the number to the ER, which could have prepared the ER to better prepare for a trauma, which rolled up as a surprise. I had out here junctional tourniquets, and there's the abdominal aorta junctional tourniquet, TXA and calciums. Good thing in what they knew, I don't know that you could have gotten there. But a little bit more exposure, a little bit of understanding about the wound pattern, maybe these things would have been like an appropriate thing to consider. This, I think, is a shiny light. There was already a blood draw donation event planned at Madigan around this time frame, but knowing this, again, on JBLN, this was relatively well known that this patient showed up and used 78 and survived. And the ASBDC set up here, and they had more donors than they had capability to draw blood. So they got about 120 units out of this donation event, and about 300 people showed up to donate, and they just couldn't take it. So that's us doing it then, right? My shameless shout-out for a previous lecture, but it was this event that caused me and my medics at Second Battalion in First Group to ask, why don't we have blood at our randies? And in fairness, this guy probably, based off of his vital signs, may not have gotten blood at the ranges, but when you think of the amount of blood that this station used, and the fact that it happened on a First Group range and we didn't have blood to give him, if he did, we get known to. So we now have conserved blood at the point of injury that's now relying on walking blood bank, and that's entirely because of this patient. I'm going to get her back to Dr. Leonard. He'll talk a little bit about the hospital. But again, this patient lived because of the care that was provided. There's just many things we can learn from this case.
Okay, so some of the things that we can learn on the in-hospital side of things, essentially, echoing this is not to discredit any provider that was on that night. Ultimately, the patient got him to go help carry he needed. So the big thing for me was kind of the initial vitals that we saw. We have a heart rate of 132, and you have this blood pressure of 176 over 146. And I don't know if we can trust that diastolic. I think it probably provided a little bit of reassurance initially when he rolled in, and that was the first pressure that they received. But a young, healthy 26-year-old should not have a diastolic of 146. And later you'll see that the blood pressure is a little more congruent between the diastolic and the systolic. But really, I think he must have had a cup that was ill-fitting, whether too big, too small, poorly placed. And that's why we saw that. Another thing we kind of figure out in terms of vitals as well is before he went to CT, he got that repeat set of vitals, which showed at that time that he had a heart rate of 125. He had a systolic of 125. You calculated his shock index at that time, it was 1. And so, yes, a heart rate can be elevated due to pain or, discomfort. Was this patient hyperventilating? Is that why he had this, increased respiratory rate? Was he just stressed out of everything that was going on? So there's reasons to kind of think, hey, maybe this heart rate isn't necessarily real, but we have concern on the pelvic X-ray, obviously, that there is some type of shrapnel within his pelvis, and he does have this heart rate that's elevated. So I think, with that shock index of 1 at that time, it's possible interventions were performed at that time. Things would have, just happened a little bit earlier for him. The other big kind of thing to learn about this case is the blood product return. So the emergency release blood that came out with that full trauma activation ended up being sent back early prior to having the CT results. And so oftentimes what will happen is they'll hold on to the emergency release blood until you get a wet read, essentially, of your CT scan, saying, hey, we're not seeing any massive active hemorrhage anywhere. So I think that was something, that delayed a little bit of time because the blood bank is down in the basement. It's, again, down a hallway, down another hallway, and then another hallway. And so we had to send a runner to get that. And then they also had to prep the blood at times too. And so that took a little bit of time. And then the MTK went to the OR, despite having to have this turnaround and route the patient come back to the EA for that intubation. And so I think always remembering, hey, let's keep the blood product with the patient, would have kind of solved some of these issues and not have led to 10-minute delay or additional blood product. We'll talk a little bit about Rabo in a moment, Dr. Radloff, but I think it's important to understand the limitations to a FAST exam. And so really for a FAST exam, the standard teaching is that we do a FAST whenever there's anybody who's hemodynamically unstable and they have a blunt mechanism of injury. And so at Madigan, because we're a training facility, we just do a FAST exam basically on every single patient for our providers to work on their skill set. And so the new thing, though, that is essentially being recommended by ATLS and JTS is, hey, maybe we should consider a FAST exam for all traumas as a secondary adjunct. And so a fast exam was really good if it's positive. And unfortunately, it doesn't encapsulate every type of bleed, and there has to be a certain amount of blood in that area at the time of doing the fast exam. So it's very, very poor at picking out the retroperitoneal bleed until there is a massive amount of blood that has been lost. So I would argue, in any patient that has abnormal vitals, Stark's become unstable, has a negative fast, C1-repeat, then this patient did have a positive on pre-fee, that you should consider that it is a retroperitoneal hemorrhage. So I know Dr. Radlott loves to talk out with
Kira is sending me up here for all the unpopular comments. If there's Revoa lovers in the audience, I apologize. I'm not a Revoa lover, and I've been so enough time stay here. Revoa yet freaked as a POI adjunct. I've only been in the hands of 18 others. I disagree strongly. There is one instance where Revoa is absolutely appropriate, and sadly it's this guy, right? Like, this is the guy when the surgeons are there, the OR is ready, and he's crashing right now. That unfortunately this guy didn't get the Revoa placed in the DR. He went up to the OR where Revoa was placed as an adjunct waiting for vascular surgery to come and cross-clamp the aorta. I think also sadly for this guy, we know that the clamp was in place for about 30 minutes. We don't know how long the Revoa was up. There are some studies that will tell you 2 hours is maybe appropriate to have the Revoa, but most live animal studies and really pretty widely accepted now is anything greater than 30 minutes is going to cause permanent end organ dysfunction, which this guy has. I think, again, we absolutely saved this guy's life with the interventions that we did, but the reason he can't move his foot right now is because we have to have Revoa for a very long time. And again, she said to me after I said that I get all the Rotten Tomatoes thrown at me. Revoa has a very specific niche, and while I generally don't like it, this is that very specific niche, and it was not used right here. So, throw your tomatoes, if you will.
Hey, folks. So that's all we have on this case for this individual. Any questions that I can take in the last 3 minutes? I also have a post earlier this evening, if you will ask in private.
Say loud, so I'll repeat. Oh yeah, hey, let's culture Army Mills trauma surgeons that always just but just want to say, as for the blood pressure and vital signs of the beginning, this is an exceptionally good example of that's what I expect actually. So that profound tachycardia, profound diastolic hypertension, even systolic hypertension, is exactly what you see in a fit young person right before they got. And the reason is that they have so much Hab-Ole response that all their blood vessels clamped down, and they tried that diastolic way up. That's his body trying to not react. So this is just a great example of how to pay attention. And the one comment that I wanted to make for you guys is congratulations, please, on presenting hard things. Nobody wants to brief bad news. Nobody wants to look at red boxes on tracker. Nobody wants to talk about it on Spark. We all want to celebrate our victories, but when we do something and it doesn't go exactly the way we want, that's what we have to talk about. So kudos for presenting the hard cases. I agree there are things that could be done differently in this case, but man, we don't learn from and talk about it, so thank you.
Thanks, sir.
So I'm Evil, and as a BAFC, I'd rather have to admit some crap to me, and it's the law, sorry. My only question, biggest question, first off, congratulations, very hard case. He survived, life defect. Secondly, when you knew he had a bilateral PI artery injury, was there any discussion getting central access above the diaphragm, knowing that you're putting a catheter in the veins running right next to that transected artery?
Yeah, that's a great question. So this is actually a case that was on the prior shift to be cutting in. So I don't cap that detail. I was trying to find that answer as well, actually, in the notes to talking with the providers that were on for this case. And they didn't have an answer at that time. I think part of it was prep A, essentially, per intubation, and thinking they were going to roll. I think there were just a lot of people sometimes up at the head of the bed, and that's essentially why things get pushed down. But I couldn't find that in there, so I'll address that.
Well, I'm sorry, one last comment, that the arrest on the intubation is also the expected event. I think it's worth mentioning that resuscitation is what keeps that happening. If you can jaw thrust somebody and you can mag up, you can get them to the OR. And I've taken a number of patients with the GCS that say you should be intubated and to the OR, not intubated, so that we can intubate the laparotomy simultaneously. So I think that would be I think that's another thing that can be a useful discussion point to remember, that without resuscitation, intubation is dangerous.
Yeah. That absolutely.
That's sure thing. I don't know. Is this on?
No. Well, it's something's on.
I think, to your point, I think that's great. Recognizing that a 26-year-old has pretty substantial hypertension, systolic and diastolic, isn't reassuring. Whether it's realistic or not isn't reassuring. And then recognizing that vagal stimulation from intubation in that guy who's now got no catecholamines left is particularly bad news, right? And so, again, this is not strictly AT delta TOI badness, and is not strictly ER badness. It's not strictly trauma service badness. There's a lot of stuff we could have done better. And I think you're right. So we, as a doctor, I get used to M&Ms and we talk about badness. But it is, and having grown up as an AT delta, it hurts people's feelings when somebody says things didn't go good. And so we often shy away from doing that, and it hurts the confidence that the team has in their medics, and now this guy's maybe got a bad reputation, which isn't fair. So it is something that we need to do when we can see it and call it out and say, you're not the only guy, man. The other people are going to do it wrong, and we can fix it.
All right. Well, thank you, everybody. We're over time, so if you have any additional questions, because somebody had post earlier. Thank you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.